arm, correct? That's the broken one.
Let's
So
switch.
left
She
marker.
get behind me because we need the video to be priority. Here, she can get like.
And then breathing instructions. So now here is the interesting part. There are two ways we can do our breathing instructions. The first way is just take a deep breath in and hold it, right? Suspend on inspiration. However, if you want the best possible picture, we have something called orthostatic breathing. Okay, orthostatic breathing. What this means is that we are going to do an exposure that lasts 3 to 5 seconds long. Normally your x-rays go beep, right? Super fast, half a second or less. But this time when we do our x-ray, it's going to go x-ray, it's going to last a while. And the idea here is we are going to make use of this time and have the patient create motion. So during this time, the patient's going to be breathing, right? So the lungs are moving, the heart is moving, and when they breathe, and you're doing this long x-ray, it's going to create motion in the image. Normally, motion is bad because we want to see anatomy holding still. But if I don't want to see that anatomy, right? Like I don't want to see the lungs. If the lungs are moving, it blurs the lungs and they kind of remove themselves from the image. And now I have a much more clear picture of the stuff through the lungs. In other words, I have a much more clear picture of this left arm. So orthostatic breathing. Tell the patient, all right, I'm going to need you to take in some short, shallow breaths. So in and out, just breathe, in and out, in and out. Good, keep breathing, keep breathing, keep breathing. X-ray, yay, 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 yay. Great. Relax and breathe normally. Does that make sense?
Yes, it makes sense.
Those are our breathing instructions for orthostatic breathing.
So, do you normally tell them like a certain number, like, or do you just like, or?
Just tell them, right? Just breathe in and out, shallow breaths. Just, right, just in and out, shallow breaths. Okay, that just moves the lungs slightly, wiggles them, right, blurs out those lungs. Okay, any questions about the transthoracic humerus? Right, one more time. Right. Looks something like this. All good? All right, thank you, Regan. Let me take this off you. Okay, so next up is going to be the shoulder. Who would like to be our patient for the shoulder? If you hold this around the front, spin around, and I'll Velcro it in the back for you.
This one?
No? Just hold that around the front. There you go.
You might need the extra large.
Oh, all right, might need a big one.
Yeah. Oh, here else. Yeah, no.
Yeah, this is kind of heavy. Hold on to that if you would, please.
Oh wow, yeah, that's the super. They're usually a little larger than that, but not that big. Yeah.
Hold on to the front.
Seems like you guys
just the strap here. A little bit more.
Yeah, that one looks like the ones that we wear in actual clinic.
All right, great. So, for the shoulder is smaller anatomy, correct?
Mm-hmm.
So what do I need to make sure to do?
Change the cassette.
That's right, we're going to change out this cassette. For the shoulder, we are going in crosswise. So, how tall is this? Crosswise is 10.
Oh yeah, 10.
So I'm going to take this, pop it over to 10, take this, pop it over to 10. Fits perfectly inside. Make sure this clamps in. we're good to go. By the way, the machine will be able to detect what the cassette is like inside if you properly clamp it in. So it will give me the correct collimation in the correct orientation. So, for the shoulder, our palpation point is going to be the coracoid process.
Okay.
Where is the coracoid process?
I don't know exactly.
So the idea is clavicle, underneath, head of the humerus, towards the middle. So it's somewhere medial to the humerus and inferior to that clavicle. So my coracoid process would be right here. Are you able to find your own coracoid processes?
Medial to the humerus and inferior to the clavicle.
Correct. So do you mind if I copy?
Okay.
So here's clavicle, here's humerus. So coracoid is this one right here. This bump right there.
Okay.
Reagan's is pretty easy to palpate. Normally it's not that easy. Let's see. Were you able to find yours?
Yeah, I think it's like right here. Like it's probably right here.
That's good. Right here, you said?
Yeah.
Tough to feel, but I
What
think
are we
you're
looking
correct.
for exactly?
Yep, that's the coracoid.
The coracoid? Or are you talking about like how it feels?
Yeah, like where am I feeling for that?
So, to feel for the coracoid, you're going to start here at your clavicle by the acromion end, and you're going to go slightly down, over here by the humeral head, just slightly towards the middle, and it'll be somewhere in this region. So you feel around for a small bony bump. For me, it's right here. So here's the head of my humerus, and here's the top of my clavicle. There's a humerus, clavicle, just underneath the clavicle and medial to the humerus. Is this small
Okay,
bony
I found
bump.
it.
All right, very good. So, coracoid can be difficult to palpate on patients. Right? A lot of times there's a lot of soft tissue here, there's a lot of muscle, okay, and it's hard to find that bony bump. If you are able to find the coracoid, our shoulder centering is going to be 1 inch inferior from the coracoid. But what if you can't find a coracoid? What if you're trying and you just cannot find a coracoid? There is something else you can do. If you look for the clavicle, clavicle is pretty easy to palpate, right? You can find a clavicle. If you follow the clavicle out towards the end, there is this dip right here, right above the humerus. The clavicle has this sudden small dip. Any idea what this dip is?
Scapular notch? No? Too far?
No.
AC?
That's the AC, yes. Here is the AC joint. The AC joint is approximately 1 inch above the coracoid. So, if you can't find the coracoid, you can find the AC, go down 1 inch, and that's about the height of the coracoid. Does that make sense?
Yeah.
So even if you can't palpate it, you can at least estimate where the height is, right? And then at that point, you just make sure you go medial to the humeral head, and you're like, all right, that's around where the coracoid would be. Does that make sense?
Yes.
So find the height of the AC, go down 1 inch, make sure you're medial to the humeral head, and that's about where the coracoid is. So even if you can't palpate it, you can make an educated guess. And then from here, once again, we go down 1 extra inch because our shoulder centering is 1 inch inferior to the coracoid. So we're centering right about here for the shoulder. So let me try on Shamika here. Mind if I palpate you? All right, so, okay, I see clavicle here. Okay. Here's the humeral head. Looking for a coracoid somewhere in here. Okay. I want to say this is the coracoid. No, I think that might still be clavicle. All right. Having a tough time finding that coracoid right now. So instead, I'm going to take the clavicle here, follow it up. All right, AC joint, go down 1 inch. Okay, so that's about the height of my coracoid. From here, go down 1 more inch. So this should be about the height of my centering. I'm just going to drop it down right about here. Okay, so from AC joint down here is about 2 inches. So since I can't find a coracoid right now, I'm just going to have to estimate. Now, let's say that I am looking at this left shoulder. I need a center over here by the left shoulder. So Shameik, could you step to your right, please? Good. Okay, a little bit more. Good. Right. And once again, we're going to be directly underneath that coracoid. So here's that humeral head. So coracoid's just medial to the humeral head. So slide towards me just a tiny bit. There we go. Right there. Right. So I think coracoid is somewhere in this region. I went down 1 inch. Okay. Now, from here, with this centering, you can actually do 3 types of shoulder x-rays. You can do neutral rotation shoulder. This would be your trauma view. So patient has shoulder trauma, you don't want to move the arm, you leave it hanging straight down. This is your neutral rotation shoulder, right? Basically, palm against the leg. This is not something you want to do routinely. This is only for trauma when the patient cannot turn the arm. What we normally want to do is an internal rotation shoulder and an external rotation shoulder. So let's talk about external rotation. Your external rotation shoulder is positioned the same way as your AP humerus. So what do we need to do with this arm?
Turn is you mean like with the elbow thing?
Mm-hmm.
Okay, so make sure the epicondyles are parallel.
Parallel to the
IR.
IR, very good. So we're going to ask our patient to put the hand palm forward, facing our camera, our tube. And then we're going to come over here and check the epicondyles. And now we're going to adjust the elbow back and forth until those epicondyles are parallel to the IR. And this is our external rotation shoulder. Okay, from here, we make sure to mark. Okay, we collimate to the borders of our shoulder. In this case, we're already at the soft tissue border, so perfect. And we can ask our patient to hold their breath, X-ray, you can breathe. Right? Something else you can do to help improve your image is ask the patient to also turn their head just slightly away, right? You don't want them facing you, you don't want the chin in the shoulder. So just have them turn their head slightly away. So are we okay with external rotation here? Okay, internal rotation. You position this the same way as your lateral humerus. So what do we do with this arm?
Epicondyles perpendicular to the IR.
And how do we do that?
Like a mini chicken wing.
Chicken wing, that's right. So we're going to ask our patient to turn their arm in. Slight bend, back of the hand against the hips. Okay, check our epicondyles, make sure they're perpendicular. And this is our internal rotation shoulder, right? Still an AP shoulder, just internal rotation. Any change in our centering? No, right? Exact same location. So you don't need to move the patient at all. Just take the arm, spin it, and you've got your 2 shots, external, internal, external, internal. Okay, so hold your breath, X-ray, you can breathe. These are your routine shoulder X-rays. If you see an order for a shoulder, you're guaranteed to do these 2 pictures. Okay. Any questions so far?
Okay, so just to recap real quick for the breathing, because that's the only thing that's like, you know, really, like, you know. So the humerus was, what is it called? Suspended. Okay, suspended.
Suspended on inspiration, expiration, or just respiration. So do you hold the breath when they breathe in, breathe out, or just at any time?
Respiration?
Correct, respiration. You just hold your breath at any time.
Okay, and then for the
transthoracic?
Yes, the transthoracic or Lawrence. That one is short, like
short, shallow breaths.
Yeah. And then this one was what was this one?
This one was also suspend respiration.
Okay, suspended respiration. Okay.
Just hold your breath, X-ray, breathe.
Okay.
Right. No fancy breathing instructions.
Okay. Cool.
All right. Okay, sorry. Let me get my list of suggestions.
We have the lid, the shield.
Oh no, my back's just tired.
I'll make sure that I remember everything I need to hit. All right.
How many? Sorry.
Oh, how many do we have?
Yeah.
You have 2 humerus, you have 3 normal shoulders, 2 clavicles, 2 AC joints, 2 scapula, and 4 trauma. So in total, that's 5, 9, 11, 15. Okay. So we're okay with external, internal, and neutral. So now I am going to show you the Gracie method.
The neutral, sorry. The neutral was the trauma, right?
Neutral is trauma.
Okay.
Just arm straight down, don't move it because there's a fracture here. Now, if you take a look at our patient right now, the scapula is not parallel to the IR. The scapula is actually angled like this. The joint space is not parallel to the IR. The joint space is angled like this. That's scapulohumeral joint. The Gracie method is here to open up this joint space. So we need to be able to put this joint space parallel to the central ray. So in this case, we need to oblique our patient. So for the Gracie, the shoulder of interest is going to be the one closest to the IR. In this case, we're going to do an LPO. So, Shamika, I'll just turn slightly towards me. A little bit more. Good. So, this is going to be around a 45-degree oblique. And by doing that, we're going to open up this shoulder joint right here. Does that make sense? Are we clear as to why we need to oblique?
Yes.
That's right, to visualize that joint space. Okay. Let me just double check something real quick. Reishi was, thank you. All right. So our centering for the Gracie is going to be a bit different now compared to those other shoulders. What we're going to do is, once we have our patient nice and rotated, you're going to find the top of the shoulder and you're going to go down about 2 inches, right? Because we're trying to center to that scapulohumeral joint. So find the top of the shoulder, go down 2 inches. Okay, so I need to raise this up just slightly. Okay. We're going to find the side of the shoulder and we're going to go medial. 2 inches. Okay, right now we're pretty much there already. Right. Find the side of the patient, side of the shoulder right here, and go medial 2 inches. So I'm just going to push it a tiny bit. There you go. And this is our centering. This is centered to the joint space. All right, so top of the shoulder, 2 inches down, side of the shoulder, 2 inches inside. Make sense? Right? Just 2 and 2. Keep it nice and simple. And then from here, you can just collimate in to the joint and throw on your marker. Okay. And that is your Gracie. So the idea is that we've got the whole joint space right here, and we can see straight through it. Breathing instructions, same as before. Just hold your breath, X-ray, you can breathe. Do we need to do anything fancy with the arm? No, we do not. You can just leave it hanging straight down like this. Okay.
So Mr. Donahue says it would be suspended on respiration.
For the Gracie? All right, let me double check.
Sorry. I guess I should read the textbook.
I have a question.
Yes, question, go ahead.
Can you hear me?
Yes.
So anytime that you're doing like the projections for the shoulder, do you have to have them turn the opposite way so that their chin's not in the way, or?
You don't
Does that
even do,
matter?
so not all the time, but it's a good habit. So you don't need to do it all the time, but
To
it's a
have them
good
turn
habit.
the opposite way?
Yes.
Okay.
Let's see. Gracie method. So respiration is just suspend for the Gracie. And then respiration is just suspend for the normal shoulders as well.
So this is the trauma view. Why?
So this is not the trauma view Y.
Okay.
This is the Gracie. This is actually what I would say is the opposite of the Y view, because you're taking the scapula and you're basically putting the scapula parallel to the IR. When you do the Y view, you're taking that scapula and putting it perpendicular to the IR. So let's do that trauma Y view. Okay, once again, I'm going to warn you. Actually, let me give you a few more warnings. In clinic, when you do shoulders, right? Remember how we did the lateral humerus? How they do it like this, hand on the stomach, right? Not a true lateral. When they do internal shoulders, they do the same thing. They put hand on the stomach, not a true internal. Why not?
Because the epicondyles are like almost like at a 45 degree.
That's right, epicondyles, right? Not perpendicular to the IR, so not a true internal rotation. Okay. When we do the Y view in clinic, it usually comes with the normal AP internal and external shoulder. So Shamika, back against the board, please. All right, so like, okay, here's our external X-ray, boom. Here's our internal X-ray, boom. And now we need to do the Y view. I need to oblique my patient. If you are a tech and you want to oblique your patient right now, do you think you would prefer an AP oblique or a PA oblique? Do you think you would want to do something that's LPO, RPO, or something that's LAO, RAO?
LPO.
That's right, we want an AP oblique, LPO, RPO. Why? Because the patient's already AP. I just need to turn them either this way, or I need to turn them the other way, and I can shoot my X-ray, right?
Yeah.
Here's the problem. If I was doing an AP oblique for the shoulder here, I would need to do an RPO. So turn Shamika. All right, and so I would be shooting at this shoulder right here. What do you notice?
The OID.
There is a lot of OID here, right? So yes, this is going to be faster, this is going to be more convenient for the patient, but there's going to be a lot of OID. So you will see this in clinic. They will do their Y views AP. But in lab, we're not so concerned about the patient's speed or comfort. We're concerned about getting good images. So guess how we do the Y view in lab? PA. So Shamika, if you turn around, face the board, and if you could spin that shield around as well. Very good. So for the purposes of demonstration, I am going to do this for the right shoulder, so it's easier for us to see. So Shamika, if you would turn to put your right shoulder up against the board, nice and close. Good. So the idea here is that right now the scapula looks like this, right? The body of the scapula is basically perpendicular to the IR. So that is how we're going to form that stem, the bottom part of our Y, right? And over here you've got the acromion and the coracoid sticking out.
Mm-hmm. So that is the scapula, the long part of the Y. In like superimposed, I guess.
Mm-hmm. So the long part of the Y is the body here. You superimpose the medial border and the lateral border of the scapula to form the long part of your Y.
Okay.
Mm-hmm. So, first things first, centering. Our centering is going to be at around that scapulohumeral joint. Okay. So, it's going to be centered at around the same level as your gray sheet. Right, so top of the shoulder, go down 2 inches. All right, you can drop down just maybe a tiny bit here. Okay. And so that's going to be the height of my central ray. Okay. Top of the shoulder, 2 inches, just like my gray sheet. Next up, my obliquity. And this is the part, oh, I'm sorry, I almost forgot. When I do the Y, right? Y looks like this.
Mm-hmm.
Where's the long part of the shoulder now?
Down.
Like this, right?
Mm-hmm.
What do you notice here?
The set is still on the Y.
That's right, the set is still crosswise. So let's switch this
Oh.
lengthwise first. So pop this to 12, pop this to 12. So long now, right?
Mm-hmm.
But this better fits that Y of the shoulder. Okay. All right, so let's talk about the toughest part of the Y view. How do you get a proper oblique? The idea is that you need to superimpose your medial border and your lateral border. How do you find your medial border? Well, you can palpate for it. I can actually look for the scapula and I can feel the medial border right here. So for the medial border, I'm going to go all the way up and use the superior angle as my point to represent the medial border. So this is the medial part of my scapula. And I need to superimpose this onto the lateral border. I am going to have a tough time palpating for the lateral border. So I need some other anatomy which is in around the same region as that lateral border. That anatomy is going to be the AC joint. So I'm going to reach around here. I'm going to look for the clavicle. I'm going to follow the clavicle up and around. And aha, I found the AC joint. These 2 points here need to superimpose. Does that make sense? All right, so we're following so far?
Mm-hmm.
Okay, great. So, I'm gonna hit my light. All right, da, 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 da. Superior angle. I'm gonna slide my patient forwards. Small step. Good. So, central ray is now right on top of my superior angle, correct? But, if I check the AC, which I just had. Pardon me, sorry. Clavicle. You see. This is my AC. This is my AC on my central ray. This is my AC joint here on top of my central ray.
No.
It is not. Okay, so my superior border angle is, but not my AC joint. So what do I need to do with my patient? Well, what if I just slide my patient? So slide back, Shamika. You hit the light, please.
Yeah.
All right, now is the AC joint on the central ray?
Yes.
Yes?
Mm-hmm.
Is my superior angle on the central ray?
Mm.
This one right here?
No.
No, central ray's over here, right? So how do I get these two to both be on top of the central ray?
I should need to like step closer on the other side. I don't know if that makes sense.
So Shamika, what we're gonna have you do is you're gonna turn your left shoulder slightly closer to the IR. Nope, other way. Turn towards the IR. Yep, keep going.
Yeah.
A little bit more. Stop there. And now, the superior, right? Turn a little bit more. Okay, good, stop there. So superior angle, AC joint. Oops. Okay, slide to your left, just slide, slide, slide. Okay, bring your left shoulder back just a tiny bit. Away from the IR. Left shoulder away.
This way?
Turn your left shoulder away from the IR.
Oh, wait, this way.
No, that's towards the IR. There you go.
Oh.
Okay. Right there. So, superior angle, AC joint. Are they both on top of the central ray now? Here's our superior angle. Here's our AC, right? So central ray goes straight through both of them, right? That means they are superimposed on top of each other, correct?
Yeah.
So this is the rotation I would need for Shamika to get a good Y view. Does that make sense?
Yes.
So this should be about 45 degrees, somewhere between 45 to 60 degrees. It's going to vary, it's going to change depending on your patient. So you can't just use the same angle for everyone. You need to check these 2 points, right? Check the AC and check the superior angle. For the arm position, notice that I have the arm just hanging straight down. Why do you think that is?
If you try.
Why do you think the arm hangs straight down on this Y view of the shoulder?
Is this trauma?
Because it's trauma, that's right. If it's trauma, I don't want to be moving my arm around everywhere.
Yeah.
So you will see techs ask patients to bring your hand up to the opposite shoulder, right? I don't like that, because if there's really trauma here, this is not something you want the patient to do. So just for an Y view, leave the arm hanging straight down. It also makes it easier to check for dislocation if the arm is hanging straight down. Okay, so from here, just make sure our patient hasn't moved.
So the point, the anatomy of interest in this position would be the
Scapula.
So our area of interest is going to be the joint, the glenoid.
Oh, okay.
Okay. So yes, we're going to be looking at the Y, but we're centered here kind of like on the glenoid.
Okay.
Because that's where we're going to see our dislocation.
Okay.
Like, did it pop forwards or did it pop backwards?
Okay.
Which shoulder is this?
Right.
Right shoulder. So I'm going to take my right marker, just plop it right here. Okay. PA. And then, okay, Shamika, hold your breath. X-ray, you can breathe. Are we okay with this? Understand how we got this rotation?
Yes.
Just find scapula, find AC, line them up.
So that's the superior angle of the scapula and the AC joint. Okay.
Correct. Okay, great. You can relax, Shamika.